Okay, I think we should get started. Welcome to everybody. My name is Dr. Mary McGowan. I'm the Chief Medical Officer of the Family Heart Foundation, and I'd like to welcome you to our Family Heart Foundation webinar titled Lipoprotein a, Who is Most at Risk? And we're very pleased that Dr. Abha Khandelwal from Stanford is joining us to give us our presentation tonight. Hope you all experienced LP(a) Awareness Day. This is really LP(a) Awareness Month, so that's the reason for this webinar. Next slide, please. Just a little bit of information. This webinar is really for your information. The content is not intended to be a substitute for medical advice, diagnosis, or treatment, and it does not constitute medical or other professional advice. Medical information is constantly changing. As you will hear tonight, Dr. Khandelwal will be describing some new studies around LP(a). So this information is for your information. This webinar is for your information, and some of the information may change over time. We do encourage you to follow up with your medical team for your specific recommendations pertaining to the treatment of LP(a) or other issues that you may have. Next slide. We'd like people to say hello. There's a lot of people on the webinar tonight, well over 100 so far, but you can use the chat to introduce yourself and make sure that you change the settings to everyone so everybody can meet you, and just let us know what you're hoping to get out of tonight's webinar. Next slide. If you have a question, you want to use the Q&A area of the screen. It's down below. It's to the right of chat. And if you ask questions, I will be taking those questions down during the webinar, and I'll be able to direct those questions to Dr. Khandelwal at the end of the webinar. So please make sure that any questions you may have, you put in there. Next slide. I want to thank our sponsors, sponsors for LP(a) Awareness Day and sponsors for LP(a) Community in Action. And now I want to take the opportunity to introduce our speaker. Abha Khandelwal is an imaging cardiologist who has clinical experience in the prevention of cardiovascular disease, particularly in high-risk populations. She serves in several capacities at Stanford, the ambulatory clinic chief for cardiovascular medicine and the non-invasive cardiology section. Her research spans clinical trials in preventive cardiology, as well as cardio-obstetrics, imaging, and women's heart health. She's been involved in phase 2 and phase 3 clinical trials for elevated lipoprotein(a). And we're very pleased that she serves as on the scientific advisory board for the Family Heart Foundation. Welcome, Abha, and we're looking forward to your conversation with us today.
Thank you, Dr. McGowan. I appreciate the warm welcome and very kind introduction. I'm very excited to be here and talk about lipoprotein(a). It has impacted me very personally in my family, and I'm sure several of those who are listening today. I'm going to just share my screen. Can we see my screen okay?
Yes.
Great. So I just, again, want to thank you all for taking time out of your day and evening to talk about lipoprotein(a), which is a molecule that I've been studying for the better part of the last 2 decades, and like I said, has impacted several of those around me. I may use the word lipoprotein(a), LPA, LP(a) interchangeably, but I am talking about the same molecule. And so briefly, what I'd like to do is talk about the background of lipoprotein(a) and its relationship to LDL. I will talk about the risks associated with LP(a) and screening and diagnosis, who we think is most at risk. And I will talk about the overview of how we manage individuals with this condition. And I'm very excited to share some future research that is on the horizon. So why we're here today. We all know that heart disease is the #1 killer of both men and women in this country. And we're going to talk about the biological contributors to this today, but we cannot ignore that there are significant socioeconomic contributors and geographic contributors as well. When we look at heart disease death rates across the US, with areas that are disproportionately affected in darker red across the top, we can see that there are areas where your zip code matters. And unfortunately, when we overlay poverty areas by county below, one can see that they map pretty closely together. We know that about 1 in 8 individuals during this study period were living in poverty, and this was higher for African American and Latino women. We also know that families headed by single mothers were almost 6 times more likely to live in poverty. So, though we are going to spend the rest of the time talking about the biology, I want us to remember that there are other significant factors that do contribute to heart disease death rates. So, moving on, what is lipoprotein little a? Well, it's a molecule that was first identified by Dr. Carey Berg, a geneticist in the 1960s. And when we look at lipoprotein A, we can kind of classify these different particles based on their density, their size, and their components. And so we kind of look at it on the spectrum of ApoB particles, which you can see here. It shares some structure with LDL here. There is a difference, which I'll show you in the next slide, where Lp(a) also has an ApoA component that's tethered to the ApoB by a disulfide bond. But so again, when we're looking at different particles in lipoproteins, we can look at the ApoA and the ApoB. It's considered part of this ApoB spectrum of atherogenesis. And as we know that it does, we suspect that some of it evolved from hedgehogs and baboons, and we don't truly know its function, though there are some speculations and theories as to previously it may have played a role in clotting and bleeding issues. But again, we don't know its receptor fully, and at this time don't fully understand its function in humans. So looking at this structure more closely, here we see the LDL-like core with ApoB attached to the ApoA, which you see around the sides. You can see these little kringles named after their similarity to Danish pastries. And what we can note is that, again, I'm not going to go into too much detail, but the number of these kringle repeats can oftentimes determine what your plasma levels are for the Lp(a). Also, in addition to this ApoA component, we also have this oxidized phospholipid component to this structure, which really makes this a pretty malignant molecule when comparing it to just LDL alone. And most importantly, I want you to be aware that 1 in 5 people have an elevated Lp(a). And as I was talking about before, there was a very recent study just earlier this year published by Dr. Borenson et al. That looked at a large population in the UK Biobank and looked at individuals with LPA versus LDL and looked at incident risk of heart disease. And what they found was that per particle, the LPA was about 6 times more atherogenic than LDL. Now, I just want to remind us all that LDL in general for most of us are much more abundant in our bloodstream. So they still carry the greatest proportion of overall cardiovascular risk. However, again, per particle, it is considered 6 times more atherogenic. And so going back to the structure, why is this so? Does it just cause athero, or are there other mechanisms of its action that can influence its manifestations? So first, when we talked about it, we talked about the atherogenic core with the LDL particle at the center of the figure. But we also note that there is a role in increased thrombus formation or clot formation. So we know that individuals who have elevated Lp(a), we can get plaque buildup in the arteries, but we can also have an increased risk of clot formation. And then there is some theories as well to the oxidized phospholipid causing an inflammatory property that can also cause other manifestations of the disease. So we focus a lot about heart disease and coronary artery disease. This is from an editorial I wrote a couple years ago. And we look at all of the manifestations of Lp(a). So we know that it can manifest as cerebrovascular disease in the way of ischemic stroke. We already know about the coronary artery disease, but there have been some evidence that it may be associated with atrial fibrillation as well as calcific aortic stenosis. And then we also know its role in peripheral arterial disease, which is plaque buildup in the other arterial beds. So we believe the LPA gene kind of started in the African subcontinent, which may partially be responsible for the 2 to 3-fold increase in African Americans for this condition. It then subsequently migrated out of Africa to other areas. And what we do know is that the prevalence of elevated Lp(a) greater than 50 milligrams per deciliter or greater than 125 nanomoles can affect 1 in 5 individuals and almost 1.4 billion people worldwide. There has been some data to suggest that the prevalence is higher in African Americans and Southeast Asians. This is one such example. We were part of a large observational study at Stanford called Heritage, and it enrolled over 48,000 individuals across over 40 countries. And they looked at, this is work from Dr. Shapiro's group, which was looking at a subgroup of this and the breakdown of prevalence of Lp(a) and LDL across various ethnicities. What he noted was compared to the overall group, Black participants, and in particular female participants, had higher median Lp(a) values. So 1 in 2 Black participants had an elevated Lp(a), exceeding 125 nanomoles, and what he also noted was that Hispanic participants had a slightly lower median Lpa value compared to the overall group. So how is Lp(a) inherited? So what we do know is it is a little complicated. However, if you have an elevated Lp(a), each of your first-degree relatives is at increased risk of inheriting Lp(a). So they should be considered for screening. How well are we doing as healthcare providers in diagnosing Lp(a)? I will highlight work by Dr. McGowan here, where she looked at her and her colleagues looked at over 44 million adults through the medical claims database. And unfortunately, what they found was only about 1% of adults know their Lpa values. And of note, those with ASCVD, it's not much better. So I think there's definitely work to be done. And in addition, when looking over time, we saw a great increase in 2019 of individuals getting screened. However, we see this lull in 2020 and 2021, and we speculate that potentially COVID could be partially responsible for this small decline here. And another thing to note is that anyone can be affected. It doesn't matter how fit you are. In fact, I don't know if many of you watched The Biggest Loser, but Bob Harper is a celebrity fitness trainer from that show, and he suffered a heart attack. And it was eventually noted that it was partly responsible because he had lipoprotein (a). So it doesn't differentiate whether you're fit or not. So when we look to our medical societies on who we should screen, how we should test for this, there are different guidelines and different societies. My personal view is that it's a very low risk test and oftentimes low cost, and I think all adults should be screened. But when we look at the European Society guidelines, they also think that all adults should be screened. Same with the Canadian guidelines. Our US guidelines from the American College of Cardiology and AHA, at least in the last iteration of their guidelines, did not give specific screening recommendations. But my hope is that in future guidelines, and I think that my colleagues share this view, that hopefully in future guidelines, they will address this a little bit more clearly and hopefully support some of these other guideline statements. And just to note, individuals who have very, very high Lp(a) may actually have an increased risk of cardiovascular disease similar to those with familial hyperlipidemia, or FH, which is another condition that you all may be familiar with. So, one of the arguments I get from some of my patients is, well, why do you think it's appropriate to measure Lp(a) in everyone? And to me, it's a risk factor. It's an independent risk factor associated with an increased risk of heart disease, stroke, and aortic stenosis. So I think it's important to know. I think it's very common. So I think it's very easy to pick someone up. It's something that you don't have to do over and over again. It's genetically determined predominantly, so it remains relatively constant throughout one's lifetime. And I do think that it is complementary with regards to other lipid testing, so it can kind of additionally risk stratify individuals beyond their traditional lipid panel. To me, I see a lot of high risk younger women. I think the potential for early intervention is huge. If you can identify these individuals early, you can work on their other risk factors and potentially prevent future disease. I think at least initially we should try for cascade screening. So if we do identify someone with elevated Lp(a), getting all their first degree relatives screened would be important. And I think in the next couple of years, we may see increasing therapeutic options available. So in order to effectively utilize these options, we need to identify those who will be most benefited. I think that universal screening, it kind of is more appropriate when you look at it through an equity lens. So you can detect disease regardless of a person's zip code. So I think that's also an important thing to think about. And I think by screening, you're engaging our patients and increasing their awareness and making them really partners in their healthcare. So I think that's very important. And if we look at all the other screening measures that we do, I do think it's a very cost-effective, long-run intervention. And just again, to highlight Dr. McGowan's work, unfortunately, less than 1% of the population has actually been tested at any point in their life. And so we as healthcare providers have a lot of work to do here. When looking at LPA values, one might ask, what is a normal lipoprotein A and what's elevated? We consider it elevated when it's greater than 50 milligrams per deciliter or greater than 125 nanomoles per liter. How may your healthcare provider document that you have an elevated Lp(a)? Well, luckily in 2018, we had ICD-10 codes that were approved and may be added to your medical record for elevated lipoprotein A or family history of elevated lipoprotein A. And I alluded to this before, but is this a test that we need to do every year, every 6 months? No, I don't think so. I think it is fairly stable over an over an individual's lifetime, with some minor exceptions. So we generally reach our adult level of LPA by around the age of 5. There are some exceptions for later in life where the values may change. So menopause may change the values for Lp(a) and sometimes substantially. We know that estrogen can lower Lpa, and in menopause, estrogen does decline significantly. So we may see as much as a 20% increase in Lpa around that time. We're also aware of Lpa as an acute phase reactant. This means that it can actually increase when there is a major physical stress or illness, infection, an acute heart attack, or major surgery. But what we do know also from one of the Novartis pelacarsen studies, one of the newer treatment option studies, that there are some natural biological variations, and in some individuals, it may be as much as about 20%. How do we manage these individuals with elevated Lp(a)? Well, when we look at the EPIC Norfolk study of about 14,000 individuals, what we found is that individuals with high LPA but few cardiovascular risk factors were 66% lower risk for cardiovascular disease than those with multiple cardiovascular risk factors. So, what we tend to do is and I'll go over this a little bit more in another slide, is we really focus on looking at the cardiovascular risk factors that are under our control in these individuals for our current state management. And so when we look at treatments, I saw some texts in the chat earlier asking, what are the treatments for this? I'm going to start off with an old but good medicine known as aspirin, a baby aspirin. And this, again, is hot off the press. Dr. Samikis's group just earlier this year looked at the MESA data set, which is a large group of individuals that previously did not have heart disease, and looks at aspirin users and non-aspirin users. And what he found in this graphic, you can see, so in the two shades of red are those individuals with elevated lipoprotein over time. And what we see is in the darker red, those without aspirin use have future cardiovascular event rates. But the ones in the bright red are a little bit closer to those that have lower Lp(a), whether they used aspirin or not. So overall, he noted a 46% reduction in cardiac events in those individuals with elevated lipoprotein A who took a low-dose aspirin compared to those who did not. Now, as a healthcare practitioner and as a physician, all of these things have to be individualized and discussed on a per patient basis, because we also have to look at the risk of bleeding. So as I said before, there are other things that we can look at as well, including your other cardiovascular risk factors. So though diet and exercise may not immensely impact the value of your lipoprotein A, they are actually very important in managing patients with this condition. We recommend a very aggressive diet and lifestyle plan for our individuals with elevated lipoprotein A. We will ask them to reduce their saturated fat. We'll ask them to take a high soluble fiber diet. And when they're unclear if there are ethnic specific dietary concerns, we'll refer them to a dietitian who can work with them on a proper meal plan. And we do recommend regular symptom limited exercise. And then we work individually on the patient or on the individual based on what their other cardiovascular risk factors are. So if they have high blood pressure, if they have diabetes, metabolic syndrome, if they're overweight or obese, if they're smoking or not active, and we will aggressively intervene upon each of these risk factors based on what the individual needs. And, one of the cornerstones to treating patients with this condition is also treating their LDL. And we have now a huge armamentarium of treatment options for individuals to get their LDL to lower targets. We know that diet can lower LDL by 10 to 15%. We have statins, we have medicines like bile acid sequestrants, we have some newer agents called PCSK9 inhibitors that really can reduce the LDL by a very significant value. And then we also have agents like bempedoic acid and Zidia that can also reduce LDL anywhere from 15 to 30 to 40%. So we have a lot of good options in treating LDL. And in fact, some of these LDL therapies can influence LPA as well. So, as of now, diet, there's no significant impact on LPA. There may have been prior data looking at saturated fat may lower it slightly, but this is not recommended. Niacin can lower LPA by 20%, but I'll talk about that more in another slide. Statins can raise LPA by up to 10 to 15%. But again, when looking at the individual, our goal is to lower their overall risk, and LDL is still a critical component of that. And so it becomes a discussion, and we do not withhold statins for this small rise in LPA. And then we're not aware of any significant effect with bempedoic acid or Zidia on LPA. We know that PCSK9 inhibitors can reduce it anywhere from 15 to 30%. and estrogen and lamidipide can also lower it slightly. The only FDA-approved treatment for LPA reduction is lipoprotein apheresis, and I will go more into that in a future slide, but it can reduce your LPA values by almost up to 35%. And it's FDA approved in individuals who meet very specific criteria. So when we talk about estrogen, we had a similar kind of discussion about this when we were looking at LDL treatment. But what we do know is that estrogen lowers LPA, but data from the Women's Health Initiative and some other studies found that hormone replacement therapy itself has increased adverse events like breast cancer, blood clots, and stroke. So it is not routinely estrogen is not routinely recommended to lower Lp(a). And again, the reduction is pretty marginal comparative to some of the newer options I'm going to tell you about in a brief moment. Niacin can also lower Lp(a), but again, there was not a benefit found in patients who are already on a statin in other studies. Also, I will speak from my perspective, and I think each physician has their own view on this, is that niacin comes with a lot of side effects. And so I don't routinely use it because it can increase blood glucose, there's GI bleeding and risk of gout. So it really has to be an individualized risk-benefit discussion with your doctor. I spoke to you about PCSK9 inhibitors, and we know that they can lower LPA by anywhere from 15 to 30%. And two of our major outcome studies for these agents, called Fourier and Odyssey Outcomes, both demonstrated that LPA reduction may have contributed to the ability of these agents to reduce cardiovascular events. But as of right now, PCSK9 inhibitors are not FDA approved for LPA reduction. And then, as I mentioned before, lipoprotein apheresis, it not only lowers LPA, but it actually lowers LDL as well. It is a commitment, and it takes time and is costly, but it can be an option for individuals with established cardiovascular disease and persistently elevated values, and for the treatment of LPA, as I said. So this is the part that I'm very excited to share with you. There are a lot of new therapies in development for Lp(a), and I'm going to just briefly talk about the general mechanism of action of these new class of agents. They all have their subtle differences, but this product is the one that I was most familiar with as we were part of like the phase 2 studies for this. Was they all work on your genetic transcription, and so like you have your DNA, that's kind of your blueprint. And then it translates to mRNA, which then kind of manifests and builds the offending protein. So what you can see here is a lot of these agents that are being developed are called antisense oligonucleotides, and they work right here from the mRNA to the protein transcription. So they're very, very specific, they're very, very targeted, and they're very effective. So all these other agents I was telling you are reducing LPA by 15, 20, maybe 30%. In our studies with Ionis, we saw the reduction in LPA almost 80%. So very impactful in terms of its ability to reduce lipoprotein A. So again, as I was alluding to, this is probably the most mature agent that's being studied. It's from Novartis. Pelacarsen is the name. It's an antisense oligonucleotide and can lower LPA by 80%. And we've already closed enrollment for the Horizon trial, which is a phase 3 outcomes trial. It's a secondary prevention study looking at subcutaneous injections versus placebo per month. And it will continue for about 4 years or until we have about 993 events, and likely be completed in the next year or two. After this, we have Amgen's particle. It's also a small interfering RNA called olpasiran. They are near trial completion for enrollment, I believe. And, they have about 7,000 individuals enrolled. Again, this is a secondary prevention study looking at individuals with LPA with value greater than 200 nanomoles per deciliter. And they have to have had evidence of atherosclerosis atherosclerotic cardiovascular disease, and it's a subcutaneous injection every 3 months. And their preliminary phase 2 data says it may lower LPA by up to 95%. Another product that is starting enrollment is lepodisiran by Lilly. Again, another small interfering RNA. ACCLAIM is a randomized, double-blind, placebo-controlled trial to look at this agent in individuals with established ASCVD and those at high risk. So this is one of the few studies that's looking both at secondary and primary prevention in high-risk individuals. And it's going to attempt to enroll about 12,500 individuals with a significantly elevated LPA value. I'm going to continue briefly on some of these other agents. There's another small interfering RNA from Silence Therapeutics called zerlasiran. Again, it's in a phase 2, looking at LPA greater than 120, and I believe this is also a secondary prevention trial. And muvapalin actually had some of its origins at Stanford, is another product by Lilly that's being studied, looking at ApoA and B bonding and looking at the hepatocyte level, but hasn't yet entered phase 2 trials. And then there is actually another therapy for LDL reduction, which is kind of a CETP inhibitor. So when we have these cholesterol particles floating around in our bloodstream, they often, components of it are transferred to different particles, making them, LDL, HDL, VLDL, these various cholesterols. So abcitrapib is one of those that inhibits kind of this transferring of some of the particles. And its current dosing strategy is about 10 milligrams per day, and it can reduce LDL by almost 50%, but it also lowers LPA by about 56%. And so they are conducting a 9,000 patient cardiovascular outcomes trial with individuals with underlying vascular disease that started a couple of years ago, and it's hoping to complete in the next couple of years, done by New Amsterdam Pharma. So with that, I hope I've been able to give you a brief overview about Lp(a) and its relationship to LDL. I've spoken briefly about the risks associated with LPA and its various manifestations, in not just cardiovascular heart disease. We've talked about who should be screened, my opinion, everyone, but potentially those at high risk. And we've talked about, once patients are diagnosed, how we can manage them. And I've also briefly spoken about areas for future research and opportunities for participation in clinical trials. So with that, I just, again, want to remind everyone why I'm here, which is to help raise awareness. I hope you'll help me do that by kind of making a mental note of an action item that you hope to do after this webinar today. I know that you've given me your time this evening, which is a good first step, but I hope that you'll continue this conversation with your loved ones. And if they are not aware of this condition, informing them about it, and ideally having them discuss whether they should be screened with their care provider. So I wanted to leave plenty of time for questions